related to the Optimizing Newborn Nutrition um, uh, initiative. And I'm really happy to have Casey with me today. Casey Nation, if you want to introduce yourself. And then do you see just my slide, Laura? Yeah, that a thumbs up. Sorry, I wasn't looking at it. Okay, Casey, would you take a minute to introduce yourself and get us started? Oh, you're muted. I think nobody ever said the word mute so many times until 2019,
How
2020.
about now?
There you go.
Okay.
And some
Hold
of you
on.
have heard from Casey. If you didn't hear her wonderful presentation, um, I think maybe as it as far ago as last fall, I'm trying to remember what month, Casey shared, maybe it was earlier this year on the home initiative at Eccleston. So if you didn't hear that, it would be a great one to go back and listen to.
Can you hear me?
Yes.
Okay, good. I was trying to use my headphones, but it wasn't working. Um, so I'm Casey Nation. I'm a quality administrative resource nurse in the Eggleston NICU, which pretty much just means that I focus on quality initiatives in our unit and heavily involved in Project Home, which is the Children's Hospital Neonatal Consortium project that's nationwide right now for improving human milk at discharge in tertiary care centers, especially. So,
Great, thank you. And Casey's an RN and also has a master's degree in nursing, and it's specifically in, remind
in
me,
nursing informatics. Yes.
nursing informatics. Thank you. I
Yes.
didn't want to get it wrong. All
Yeah.
right, take it away.
All right. All right. So we're going to talk about World Breastfeeding Week and the theme for this year, closing the gap. So I'm sure many of us know that World Breastfeeding Week has been happening since 1992 from August 1st through 7th every year. And World Breastfeeding Week is a global campaign to raise awareness and galvanize action on themes related to breastfeeding. So the World Alliance for Breastfeeding Action declares an annual theme every year. And for this year, it's closing the gap, breastfeeding support for all. So this is important because we know that breastfeeding can act as an equalizer in our society, but we have to make efforts to ensure that everyone has the same access to breastfeeding support and opportunities so that the gap for breastfeeding equality can be closed. It's essential that we don't leave anyone behind, especially vulnerable patient populations and vulnerable mothers who might need additional support to reduce those inequalities. Target audiences um, are actors along the warm chain of breastfeeding support. So, civil society organizations, governments, policymakers, health systems, um, workplaces, communities, and parents will be engaged to close the gap in breastfeeding inequalities and breastfeeding support. So the World Alliance on Breastfeeding Action World Breastfeeding Week creates resources and graphics every year. And this year they created graphics outlining why it's important to close the gap. Starting with this one, which reinforces a lot of what we've been doing in this initiative. So, a lack of breastfeeding support during the critical first week can negatively impact overall breastfeeding intentions and prevalence. And so, in prior webinars, we've talked a little bit about this, but breastfeeding can act as an equalizer, like we said, in our society, but we have to make efforts to ensure that everyone, especially vulnerable populations, have access to the same support and opportunities. And so we've talked a little bit about how we need to plan for when things are not going to plan. So not everybody is starting in the same place. Not everybody's starting in the most ideal situation or setting to establish breastfeeding. And so, in order for breastfeeding to actually be an equalizer and all of our babies to get off to the best start, we have to plan for the unexpected and plan ahead. So, planning ahead means investing in resources. So, time, money, expertise, to ensure that vulnerable mothers and babies get the care they need. So investment in breastfeeding at all levels, macro and micro levels, um, to address inequalities is vital and can help alleviate these social inequalities. So World Alliance for Breastfeeding Action uses the same, organizes their theme each year with these same 4 steps. So inform, anchor, engage, and galvanize. And so we're gonna do 2 short polls about gaps. So get ready for the polls with your phone. I think Summer might have already put it in the chat, the links. And then I'll also present a QR code in the next slide.
So we're gonna
Oh, so here
use
we go.
the polls here in a minute, but we're going to use these steps: inform, anchor, engage, and galvanize, to apply to like adapt them to the clinical setting around supporting the establishment of lactation when mothers and babies are separated, because we identified that as an important gap that we have faced and seen in the work we're doing in this initiative. So particularly, a lot of it will apply to when mother is readmitted as well, but we're going to kind of use it in the setting of when a newborn is admitted to the NICU. So you can use the QR code here. We'll leave it up for a minute. Or you can use the link in the chat, or you can text using the information in the chat to answer the first poll, which is which patients or families are most vulnerable to falling through gaps in breastfeeding support. So we've got like when there's a lack of family support, we have like when the mothers or babies are kind of like the most sick, the most ill. Non-English speakers, that's good. If you missed the QR code, you can text. It's in the chat. You can text to the number is 2233. You can text Casey Nation 209 all together, and then your answer, and it'll show up here. All right, folks that have a lot of social determinants of health, negative NICU parents after their discharge, that's good. Moms on MAG, they don't feel good. That's true. Uninsured, babies are born preterm. These are good examples of vulnerable dyads. Parents who struggled with latching. More about MAG, more about non-English speakers. Yet I think it's important for us to be kind of really cognizant that not everyone is starting. There was a meme kind of going around recently about like not everyone is starting at the same place in the race. If the goal is exclusive breastfeeding, like some folks are starting a lot closer to that goal than others. Folks who have a lot of these reasons to be fall. These are a lot of gaps that parents could fall into. Okay, I think we can go back to the main slide deck. Here we go. Let's see. I have to skip ahead, I think. All right, so our second poll is what breastfeeding support gaps exist in offering optimal care. So I know some of the ones that have come up in the past have been like night shift is a time where it's harder for us to offer optimal care, or when staffing is a problem. So that's the next poll. I'll leave the QR code here for a second while Casey activates the second poll. All right. Oh, this one's coming up as a word
I don't
cloud.
know why the other one didn't come up as a word cloud. Maybe I said it different.
Somebody wrote ordinary situations. Okay, so even in ordinary situations, there's gaps. That's fair. Nights, having inexperienced staff, let's see what else we got here. So these are like some of the gaps, not specific to the patient, but like specific to the system. Staff. A lot of getting some staff. Short-staffed and inexperienced staff.
Yeah.
I think we know that those are really challenging in terms of providing optimal care.
And particularly illuminated in the past few years. Yeah.
For sure. IBCLC staffing. So we know that families, there's both gaps that families can fall into because of their particular situation, and then there's gaps that they fall into around the system, the gaps we have in the system. So when we line those up, there can be a lot of places that families are falling through. Discharge. It's hard with the word cloud to figure out
Yeah.
what people are writing. But I think discharge, I mean, what happens at discharge and discharge planning or lack thereof is definitely a challenge. All right, thanks y'all for participating in the poll. And we will go back to our slides around closing the gap. Oh, I can resume from slide 10 this time. All right. So some of the gaps that we considered were like young mothers, uninsured families, lack of engagement or trust in the health system. Some of these you guys identified too, like non-English speakers, social determinants of health, lack of family support. And then for the gaps, we saw things like situations that are out of the ordinary, lack of policy, low staffing periods, bias, night shift, and shift change. And we'll talk about that a little bit here. So what we wanted to kind of talk about today is moving to a more patient-centered care model when it comes to supporting mothers with establishing lactation when their baby isn't with them to breastfeed, and most typically looking at NICU admissions. So this graphic outlines this proposed paradigm shift from a more traditional medical evaluation to personalized health planning. And I'll ask Summer to put the link in the chat here too, where you can read about where the citation for where this graphic came from. But it's kind of on the left here, you see this traditional elements of traditional medical evaluation, like a chief complaint, the history, past medical history, family history, social history, the physical exam, what diagnostic tests are needed or happening, and then the assessment and plan. And when we move to a more kind of evolved paradigm around this, we're going to look from a health planning point of view at patient engagement, what the patient's assessment of is, and what the risk assessment is for them. And we've talked about lactation risk assessment, what the patient's goals are, what the provider goals are, and then working together to make a therapeutic plan and coordinate care and then track and follow up with that care. So if you think of establishing lactation and breastfeeding as a health behavior rather than like a medical state, then we need to consider the parents' goals and what's informed the parents' goals, and then provide information to ensure that, informed decision making in that scenario. So I really liked this graphic that showed how to move to a patient-centered care model. And in the neonatal intensive care unit, it gets a little complicated because the parent is not technically the patient. But we also can't just want breast milk and want more babies discharged breastfeeding and just sort of sit passively back and wait for milk to show up or not. So it can be a really critical element of the care we're providing to patients in the NICU. So using this kind of more patient-centered care model and engaging the parent, I think is a good way to move if you haven't. Yeah. So I've got like a fun little animated video. So when you take this, you'll see the tan section, the light tan section is the patient's role. The darker tan is the clinician's role. And then the blue is the shared roles. So for the patient, the personal health awareness or enhancement is around like what information that mother has about the value of her milk to the baby, our patient in the NICU. And then the whole health self-assessment is sort of like what support does that mother want or need in order to provide milk for her baby. And from the health risk clinical assessment side, we've talked about lactation risk assessment and what sort of clinical risk factors exist that are specific to that patient and mother dyad, baby, mother infant dyad. And then the clinician needs to take that information and assessment and determine what therapeutic needs are there, what education and interventions are indicated for that particular unique dyad. And then those things work together for the family and the medical team to have shared goal setting around providing milk. And is it just going to be about providing milk, or does the family also want the baby to be directly breastfeeding? And then taking that shared goal setting and moving together towards a personalized health plan. And then, of course, coordinating all the elements of those therapeutic needs and having regular follow up. And we've talked in the past about the marginalization of lactation in the medical setting and in healthcare. And I think this feels like a big lift, right? Because the current MO is sort of like to tell parents we need milk and to hope that it shows up and that we don't really have a very comprehensive strategy about how to support those optimal outcomes. So in order to do kind of look at that a little more carefully, we're going to look at two kind of extreme case examples to kind of apply this paradigm. So keeping in mind that these two examples are kind of on either ends of the extreme spectrum. Both of them involve a term baby born vaginally, but who is admitted to the NICU when the baby has bilious vomiting at around 6 hours old. So in the first case study, the mother of this baby is multiparous and privately insured, and she wanted to breastfeed, so she and knows that without the baby there, she needs to ask for a lactation consultant and a breast pump. The father, the baby, is supportive and is ferrying any milk that mother is able to express straight over to the NICU for the baby to receive for oral care. This mother's got family support. Her sister is experienced with pumping as well. And, yes, the mom has had other children, but isn't necessarily in the mode to like set up a new breast pump. So she has help from her sister, and also is helping her remember to pump at least 5 times in a 24-hour period. And in this case, the mother ordered a breast pump during pregnancy for home use and has that ready and waiting for her when she's discharged. So when the baby starts being fed, we've got lots of milk on hand. And in this family, in this extreme example of all things going right, the family has transportation, they have childcare, mother's able to be in the NICU for several hours at a time, 2 times in a day. She knows she can hold her baby. She asked to hold her baby, and it's able to bond via kangaroo care. And she's always, every time she comes, she brings her express milk. So the staff knows she wants to breastfeed, and they say, hey, the baby's PO ad lib now. Don't you want to breastfeed? So don't we wish that all of our NICU patients had all of these wonderful things going for them? So in this case study, these are kind of some of the things that, are not gaps that are really setting her ahead in terms of getting to the goal. She's had other children. She's got private insurance, so she was able to request a pump in advance. She knew to ask. She felt empowered in the system to ask for a lactation consultant to come and to ask for a pump. The father, the baby's backing her up. The baby gets oral care. Mom's pumping frequently. She's got family support. Pump at home. who got milk around because she's bringing it every day. She's there in the unit. She knows that her baby's feeding order is and that the baby's going to start feeding. She's been kangaroo carrying. She knows she's breastfed other babies, so she feels ready to go. So this is like the extreme example of all the things that could be going right. That we're hoping that all of our patients have. Um, Now I'm gonna let Casey be the other end of the example.
Yeah, we're gonna swing all the way the opposite way. Okay, so for this same baby's born term, goes to NICU for bilious vomiting at 6 hours. This is a new mom on Medicaid. She has never heard of a lactation consultant, but she does want to breastfeed. So the nurse brings the pump to her room and gives her verbal instructions. And then the next shift, the mom tries to pump, and then she doesn't get anything. So she just thinks, well, I guess I don't have any milk. Um, she's discharged with a manual pump, but her baby stays in the NICU 48 hours later. She has some issues with transportation. She's able to come to the NICU the next night to visit, but it's during shift change when she arrives. Lactation is gone for the day. She doesn't know what she's allowed to do. She doesn't know if she can hold her baby. She's worried about all the tubes and wires, so she just doesn't ask. And she didn't bring any milk because she didn't know how to store it. She didn't know how to transport it. And nobody told her that her baby would start feeds today. So they give her some formula and tell her, don't worry, we can, work on breastfeeding when the baby goes home. So some things that kind of stand out here. She's young, she's on Medicaid, and the nurse brings her a pump, but just gives her verbal instructions, doesn't actually show her how to use the pump. When she's not able to express anything, she, believes that she isn't able to make any milk. They just send her home with a manual pump, nothing else. She has transportation issues. The lactation consultant is gone when she's finally able to come. She's unsure of what she can do. So she's maybe a little afraid to ask. And then she wasn't sure how to store her milk, so she didn't bring any. And then the baby gets formula. Um, and this is like, we're saying that this is extreme, but honestly, I see this very similar situation over and over again. And it's there's a lot of I think when we get so ingrained in our environment in the NICU, we kind of forget that it's really like a different planet for these people who are coming in. And so like we really should be offering the things that are appropriate for the baby and the mom to be doing. And then another thing is like with Project Home, one of the big things is for babies to go to breast for their first PO feed. So right behind that is considering, what's the urgency of a first feed, and if it doesn't say here if this baby is on fluids or anything like that, but you know, do we need to give formula immediately? Also, the mom is there, so is pumping not an option? And at the very least, is providing donor human milk as a bridge an option? So,
Yeah, and I think I agree. This is given as an example, as an extreme example, but I think a lot of times we forget, like you said, that we're in the NICU. We might like feel very comfortable there, but a lot of people do not feel empowered in a healthcare setting.
yeah.
Dr. Pena, did you have something you wanted to add or comment or question?
Apologies, I raised my hand in error, but
Oh, okay.
agreed. It's not a rare example.
Yeah. Dr. Pena is at Grady, and I know at some of our safety net hospitals, this scenario is actually quite common. And I could give a lot of examples, but we'll move forward with not dwelling on the most worst scenario, and we're going to talk about how to address and prevent some of these like more common than we'd like to think scenarios by looking at sort of a paradigm that's going to help us help parents that are separated from their newborns with establishing a more like customized milk expression routine that's simultaneously feasible and effective in achieving and maintaining that full milk supply it's going to allow us to transition to direct breastfeeding if that's the family's goal. So these steps are going to help close the gaps, all those many, many gaps that we've seen that we see parents fall into, especially when they are discharged without their baby. So the 4 steps that we're going to look at are, one is refocusing and optimizing antenatal education and the opportunities for that. We are going to look at creating and implementing policy that prioritizes lactation support when mothers and babies are separated. We are going to provide assessment and education prior to hospital discharge for the mother, and then also make a plan for regular follow-up. So, Casey,
So
yeah, go ahead.
the first is in the category for informing. So refocusing antenatal education to optimize opportunities. So this is about whenever we're providing education prenatally to families, that we aren't only talking about the potential for everything to go perfectly and the baby to be able to directly feed at the breast, but that we're also including um, e- information about lactation physiology, and then what needs to happen in the instance of a baby and a mother being separated, or even in an instance where maybe they're not separated, but there's something going on that's preventing or making feeding at the breast difficult or more difficult. And so another thing to consider here is using opportunities where mothers are admitted for antenatal admissions or like for observation if they're high risk, considering reinforcing these education opportunities in those instances, because we know that there's a greater risk of these dyads being separated at some point.
Yeah, and this is I really picked up a lot of this when we did our site visit in Augusta. They are doing a great job at MCG, Wellstar MCG, is that what it's called now? I want to get it right. That in their antenatal unit, they make sure that there's, moms are there sometimes a few hours, sometimes a few weeks. And those are really great opportunities to like learn how to use a breast pump and provide all sorts of education and assessment, asking questions. And they're there like a captive audience, basically, right? And they're in a place to learn, maybe in a better place to learn than they will be when they just delivered a preterm baby. And all of a sudden now we're going to try to get them to use a breast pump when they may have been there for a long time and we miss that opportunity.
So the next one is in the category of anchoring. So creating and implementing policies to prioritize lactation support during separation. So this is policies that prioritize lactation support education and assessment with when the dyads are separated at any time. So, things like contacting moms, having lactation support in your unit who are going to contact moms even though they're not necessarily there. I also, whenever I see this, I think of considering policies for bridging donor human milk, whenever parents aren't able to be there in a timely fashion.
Um, somebody else started sharing, so I'm going to go back to our slide deck. Let me see if I can find it.
I'm seeing
okay?
it.
I can pull it up if I need to. Let me know.
I see it, Claire.
Oh, you do? Okay.
Well, not anymore. Okay.
Oh, here we go.
Now I do.
Okay.
Resume. Okay. Yes. So I think a lot of times our when I talk to folks about what is like who the lactation consultants are seeing and in what order, it'll be like discharges, like there's certain, like whatever your kind of workflow is, making sure that your policy and your practice prioritize the most critical scenarios, and those are going to be when there isn't a baby there asking to breastfeed. Like those are going to be your more critical. With your triaging lactation care from an IBCLC, then that should be high. But then also, and we'll talk a little bit about this, that all of your staff nurses should know should have competencies in how to teach hand expression and how to set folks up with a breast pump. And when you have a mother on mother baby whose baby is in the NICU, that they're being reminded and supported to express regularly, because they may be on MAG, they may not feel well. Like, and part of that is like knowing what their goal is, and that their goal is informed, and that they understand that in order to get to where their goal is, they need to be expressing regularly in those first few days, especially during when mothers are still admitted and the baby is in the NICU, even, temporarily. If there's a misfeeding, we need to be moving the milk. All right, so engage. In the engage step, we have making sure that we are providing that skilled assessment and education prior to hospital discharge of the mother. And I know this is kind of small, but Laura will send out the PDF of the slides, and I'm happy to set a time with anybody who wants to discuss more about these steps that should be signed off as instruction that parents received when they're being discharged without their baby. So how to use a breast pump, how to manually express milk, and hands-on pumping techniques, making sure the mother has an adequate breast pump for home use, and knows how to use it. And I have some kind of non-traditional ideas about that. I think sometimes it might even be worth a hospital considering using the parents' pump for that instruction, rather than teaching parents how to use a hospital pump and teaching them how to use their home pump. But part of that will depend on how often the parent's going to be using a hospital pump. If they're only going to use the hospital pump 2 times, and then the other 99% of the time they're going to be using their home pump, it might make sense to teach them how to use their pump from the beginning, rather than focus a lot of instruction on the hospital pump and then has education on the physiology of lactation and the role. Oh, is my volume not very,
Okay,
I'm gonna turn off
now
my
it's working.
camera I'm gonna turn off the camera just in case it's internet related. Teaching around physiology and that around the clock milk removal, and getting at least 5 or more pump sessions per day, and at least one of those being overnight in those early morning hours of 1 to 5 a.m. Personalizing the coaching and strategizing around the pumping frequency schedule. And I really think it's important to have on that discharge teaching or prior to discharge, having the IBCLC say, let's, to reinforce that frequent milk removal, say, okay, in the last 24 hours, how many times were you able to express milk? And then getting an idea of what kind of volume, where they are in progress to in lactogenesis, and then talking through the next 24 hours after discharge to say, okay, let's make a plan to pump 5 or more times in the next 24 hours. And when are you going to do it? Who's going to help you? And really doing that personalized coaching, rather than just giving flat, like pump 8 to 12 times a day. And parents are just like, yeah, I'm going to do that. And then not really thinking through what that's going to look like for them. Of course, the assessment of that particular parent's lactation risk factors should be part of this consult at or prior to discharge. Does the mother have gestational diabetes or PCOS, things like that, that are part of the assessment that you're putting into the note. And then making sure that the mother being discharged has an opportunity to follow up with a lactation consultant within 2 to 3 days after her discharge, that there's a plan to connect with the lactation consultant again, so that we can see that her milk is coming in and that she has her questions answered about storage. This education ideally involves the mother support people around who can help with washing the breast pump, who can label the milk and inventory it and make sure it's stored properly. And then who's going to bring it if the mother isn't well enough to be bringing it, or if there's cultural issues about mother coming into the unit a lot, that there's a way for the milk to be brought in regularly so we don't have that gap that families fall into where we have some milk for the baby in the NICU while the mom's admitted, and then the mom is discharged, and all of a sudden our milk maker is not on hand anymore, and nobody made a plan to help make sure the milk is getting into the unit. I see a question from Dr. Paez about, we can send some follow-up instructions, resources in the follow-up email. Okay, sorry, I skipped to the wrong step. So we just did this discharge teaching, and then to galvanize, we want to ensure that there is regular follow-up scheduled. Oftentimes right now, what can happen is, the mother's given some instruction while she's inpatient, and then she is coming into the unit and bringing milk or not, and then bringing milk, expressing milk frequently when her milk comes in and she feels engorged. And then around 2 weeks or so, we run out of milk in the NICU in a longer term admission, and nobody has really checked in with the mom. And we blow through all that milk that we got, in the first week when she had high production. But without regular milk removal, her milk supply has not fully evolved, and we run out of milk, and it's kind of too late to intervene. So having this regular kind of cadence of follow-up through the first 2 weeks where we can really establish robust long-term milk production as much as that mother is physically able to do or is willing to do based on her goals is important. So I just have this suggested cadence, and this might need to be adapted per patient, but at or before discharge, 2 to 3 days after discharge, 7 to 10 days postpartum, and then again, at least by the 2-week mark. And that in that regular follow-up from your board certified lactation consultant, you have a few of these elements. Assessment of the 24-hour milk yield and frequency, assessment of the mother's comfort and self-efficacy with using the pump, and hands-on pumping techniques to really maximize output. Doing a recall of the milk, both the milk expression sessions, how often she's been able to do skin-to-skin sessions with her infant, and whether and how often she's been able to provide oral care with mother's own milk. And then reviewing where we are with the infant's feeding order, and is it time, time to start doing non-nutritive breastfeeding or nutritive breastfeeding. In the example we had, it was a term baby. As soon as a baby could feed, then that baby should be directly breastfeeding. If it's a preterm infant, of course, we're going to have, some steps leading up to that. But as Casey mentioned, ideally the first oral feeding is at the breast, rather than through bottle feeding. And then, and a lot of times the first oral feeding doesn't have to happen at this moment, right? It can be we need to be looking at what the forecast, when do we anticipate the baby will be able to feed PO? And can we arrange for that to happen when the mother is in the unit visiting or being with her baby? Going back to the personalization, really planning that, going through her pump schedule. And, there's mothers who are like, okay, I really had challenges this week, and they need some support on how to fit in more frequent. Other mothers are pumping 8 or 10 times a day like they were advised, and they really are okay to start going a little longer. If they're pumping 35, 40 ounces in a day, they can compress their pumping schedule. And that only can happen if somebody's taking the time. So a skilled lactation consultant is taking the time to look through what her regular routine is, what her output is, kind of where she is in lactogenesis, and making a customized recommendation for that. And then as listed here, the customized care plan to address the status of her lactation, what her goals are, and then an opportunity for parents to share if they're having pain with their pump flanges, or they have questions about labeling, storage, medications come up frequently, things like that that are important in a regular follow-up with a lactation consultant. I'm going to pause there for any questions so far about these 4 steps. I'm going to hit this steps: inform, anchor, engage, and galvanize through opportunities for antenatal education, creating and implementing policy that really prioritizes optimal support when mothers and infants are separated, that kind of critical assessment and education at discharge, and then establishing a cadence for regular follow-up through the first 2 weeks particularly. And then of course opportunities go on while if a baby still remains admitted, transitioning to direct breastfeeding. All right, I don't see any questions. I wanted to bring up this graphic because I've had the opportunity, we've shared it before, and it's kind of based on this recent research around factors that mothers who were able to come to volume, which is defined as 500 milliliters or more per 24 hours, which is specific to a NICU volume need, factors that mothers had in common. And one of them was that they were their average like pumping sessions per day was increasing and kind of settled on at least 5 pumping sessions a day by day 5. The other is that really important early morning pumping session between 1 and 5 a.m. and really not going more than about 5 hours without expressing milk. And I think this kind of using these keys when we're doing those personalized, customized, specific to the patient, patient-centered education, instead of just saying pump 8 times a day, or I've had lactation consultants tell me, well, I'm worried that they're not going to pump 8 times a day, so I tell them 12 times a day so that they'll at least get in 8. I think parents really deserve information about what is evidence-based, and the 8 to 12 times a day is based on, what we all agree that frequent milk removal is key. But I think sometimes what I have run into, and maybe some of you have also seen this, is mothers just get overwhelmed with that idea and they just quit, or they don't really ever get into a routine because pumping 8 to 12 times a day seems impossible, especially if they're unwell in the early days. And so focusing on saying we're trying to get to at least 5 times a day can feel more doable. And, we're always going to have parents who pump, exactly as instructed. So you can talk to them about how we're trying to replicate the baby by expressing milk every few hours. But I think it's okay to also say, give yourself some grace and have a goal of at least 5 times a day by day of life 5, and breaking up that overnight stretch with at least one pump session between 1 and 5 a.m. can make it seem more doable and more customizable. And part of that is like looking at what the mother's support is. Does she have support from her partner, from her family, or is, how convinced is she that this is even what she wants to be doing? Then it can feel more doable, and it can be more achievable to set that goal of not going more than 5 hours and pumping at least 5 times in 24-hour period. So Casey and I kind of strategized about what are some ways that we can make these steps happen. So here's where I would love to hear from some of you all. If there's anyone who has established a multidisciplinary breastfeeding or infant feeding team as part of your work with the ONN, I'd love to hear how that experience went for you. You can come off mute or raise your hand. Meanwhile, I think some of the things that can be done in your multidisciplinary infant feeding team or task force or committee or whatever you're calling it is really looking at whether your practices and policies are aligning with your priorities. And I'll give an example and I'll let Casey give some examples. But I heard from a neonatologist, I may have shared this here before, one time who went and did a visit at another NICU. And she called me and she said, Claire, when I went in their NICU, they had a breast pump at every bedside, at every bed space had a breast pump. And I said, what did that mean to you? Right? Like, what did that communicate to you? And of course, I know a lot of you on the call do have that, but for those of you who don't, and coming from a unit that didn't have that, like, this neonatologist was really impressed because to her, it really communicated that the structural support in the NICU reflected what their priorities were in their NICU. And their priority was human milk being the standard in their unit. And so they had a breast pump at every bedside, just like they had other medical equipment that was necessary at every bedside. And that communicated to this neonatologist probably what it also communicated to staff and families was, if we want you to be using the breast pump, but then we have to go find a breast pump, like send a tech to another floor or go in a closet and dig up a breast pump or get systems that tag where your breast pumps are on like a GPS system because you don't have enough of them, that's communicating something that doesn't align with what your priorities are. Casey, which one of these do you want to talk about?
Well, and I would just say to piggyback off of that, when you can have all the breast pumps, but if nobody in your unit knows how to teach a mother how to use the breast pump, then you're also communicating, oh, we have all this equipment, but we don't have anybody that can teach mothers how to use that equipment. And so again, that yeah, or if you don't offer the breast
Yeah.
pump, yes,
Yeah.
or offer to teach them how to use it, right? So, and then I think space for storage. I mean, I think it's a huge problem in many places. But it's kind of like, what are we communicating to parents if we're like, oh, we can only take X amount of your milk? Really,
Mhm.
what we should be saying is, we want all of your milk. We want you to bring it every single day, every time you can, and we'll keep it here. And like, you know, you're also considering the fact that you're eliminating the need for them to potentially have to figure out storage themselves, which is a whole different thing, right?
Oh yeah, I didn't think of that when we were talking about that, but that's a good point.
Yeah,
um
because like most people aren't expecting to need like a huge deep freezer just for their milk, right? So
Right,
yeah.
and that's something that, like, if the mother and family are having regular follow up with the lactation consultant, then part of that follow up is assessing where we are with milk volume, right? And so then it can be like, okay, it looks like, you had a 28 weeker and you're pumping 24 ounces a day, right on. We're basically never going to be able to use like a big chunk of this milk, right? So either, working with the family to get their own freezer space or working out what our scenario is at the hospital. But when we focus a lot on not having enough freezer space, we're also not thinking about using fresh milk all the time. And that's something that comes up a lot in the work we do with NICUs is like, oh, whose job is it to communicate to the parent to bring more milk in? I was like, they should be bringing in fresh milk all the time because fresh milk should be your priority. And then if we end up with a lot frozen, then we can talk to the parents about getting a freezer for home use. But the idea should be bringing in fresh milk all the time because the fresh milk is going to be the best, and should be in the policy as being the priority is using fresh milk. So yeah, when we say human milk is our standard and we want to increase the number of babies going home on breast milk, but we don't have enough freezer space or enough refrigerator space, our practices are not aligning with our priority. Some of the other things we mentioned, that I know have come up as like, if we want to prioritize um, skilled lactation care for our most vulnerable dyads, and that's going to mean really evaluating what your IBCLC staffing paradigm is. We've talked about that in a few webinars. I've got resources on that if folks are working on that as part of their discussion on their infant feeding team. It can also look like Casey and her unit in the home initiative talked about getting a cohort of nurses that do have additional lactation training so that ideally there's somebody on every shift that can be a resource, even if you don't have IBCLCs, like on your night shift, for example, things like that. those folks can be resource nurses around your policy and around common practices, like how to teach a new person how to set up a breast pump, or be checking your freezers, or can be doing lactation rounds on the night shift to make sure that babies that could be directly breastfeeding are, things like that. The provision of supplies came from an experience I had where we had nurses who were giving, the teaching sheets and good instruction about frequency of expressing. But at the time we had Snappies, milk storage containers that came in a bag of 10. But a lot of nurses were like taking out like 4 or 6, or not even giving a whole bag. And if you're telling somebody we want you to pump 5, 10 times in a 24-hour period, but then only giving them 4 Snappies or 6 Snappies, that isn't lining up our practices with the reality of what supplies a patient is going to need. And if you go back to some of the other talks we've done, having a place where parents can have the self-efficacy to collect the supplies they need on their own, rather than them having to ask nurses for it, can help build that self-efficacy and help the parents feel empowered to be getting the supplies that they need to collect their milk safely for their baby and transport it. So hard-sided containers. I think most folks participating have that in their NICU. All right, I just realized we've been talking a long time, so I'm going to skip forward. This is a cute little story about everybody, somebody, anybody, and nobody. There's an important job to be done, and everybody was sure that somebody would do it. Anybody could have done it, but nobody did it. Somebody got angry about that because it was everybody's job. Everybody thought anybody could do it, but nobody realized that everybody wouldn't do it. And it ended up that everybody blamed somebody when nobody did what anybody could have. And that's kind of a confusing story, but the message is that if no one takes responsibility for something, nothing's going to get accomplished. And we hope that everyone participating today will feel that there's something that they can do, that everybody here today feels like somebody that can close the gap for families that we're working with. The rest of this week and the first 2 weeks of September are kind of getting tacked on to breastfeeding month. We've got, we just had World Breastfeeding Week and Indigenous Milk Medicine Week coming up. We are ending Indigenous Milk Medicine Week and looking at Asian American and Native Hawaiian and Pacific Islander Breastfeeding Week. Their theme is Bridging the Gaps. As well, Black Breastfeeding Week is coming up. During Black Breastfeeding Week, we have our EPIC webinar that you saw, and you see there'll be Workplace Lactation Week and the Hispanic Breastfeeding Week, Reclaiming Culture Through Lactation. We'll make sure all this information is in your follow-up. And I'm going to stop sharing so that Laura can wrap us up.
Awesome,
I don't know how
thank
to
you.
stop sharing. Oh, here we go. Stop sharing.
Perfect, thank you,
Yes,
Claire.
thank you, Dr. Pena. I like your comment that we all play a role.
Absolutely, absolutely. Alrighty. Here in a moment. Oops. I apologize. I had selected the slide and it didn't want to cooperate. There we go. If you'll record your attendance, that would be much appreciated. And I am stopping recording. So if anybody